My name is Sandy Bloom. I'm a physician. I am Associate Professor of Health Management and Policy at the School of Public Health, Drexel University, and I'm the co-founder of the Sanctuary Model. I'm a psychiatrist by training, and I came to recognize trauma as an issue really as a result of our patients. We were running an inpatient unit back in 1980, and around 1985 we started to recognize that most of the people we were treating who had really very complicated problems were actually had been abused as children. And neither me nor my colleagues had learned anything about what that meant or anything, because there was very little in the literature at the time. So it was really a result of listening to my patients, and I'm starting to really understand what they had been through, and that led to a whole different way of really understanding them and responding to the problems that they had and their needs. There were many people that influenced what happened to me as a result of understanding and learning about trauma and adversity. There were a couple people who really kind of stood out early on in the process. People who were adults who were often very successful but struggling with enormous pain that was left over from childhood. The one person that I wrote about in my first book I called her Dawn, and she was a lovely young woman who came into treatment because she had accused a man on a college campus of raping her, and the police investigated, and it hadn't happened as she recalled it. And I didn't know what to make out of that, because she wasn't lying, she was misremembering something, but I didn't understand it for another 5 years. And then she came back into treatment in an emergency because she was suicidal and been using drugs. And I had thought everything was taken care of. I thought she was well and recovered, and turned out she wasn't, because we had never really gotten to the actual trauma. And she was, as it turned out, a survivor of incest. And I could have known that long before. It's just that I didn't have a framework to understand what it was I was seeing, what she was telling me. I couldn't interpret it correctly because I didn't know about trauma and adversity and dissociation. And it was really her and her experience that really brought home to me how important this subject was and how other people had to know about this. That experience for me with Dawn pretty much changed the whole direction of my life. I didn't know it then, at the time, but in retrospect, everything changed after that. And I think I was working in a team, and we all had somebody like that really changed our lives and our direction. And the way it began was we just started asking our other patients about their experience in childhood. And lo and behold, what we discovered was that most all of them had had really bad things happen in their past. And so we started trying to figure out what that meant. I mean, what that meant for what we were supposed to do in a short-term acute care psychiatric setting. And we all also had an outpatient practice. So we really started asking the question, what does it take to really create a safe environment? And at the time, the first chapter on the inpatient treatment of trauma survivors, which was directed at Vietnam vets, had come out. And the author, a guy named Dr. Steven Silver, he talked about sanctuary trauma, and he meant what happened to the Vietnam vets when they came back to the country, that they expected a protected, safe environment, and they found more trauma when they were greeted with a lot of negativity because of the war. And I read that and went, oh, sanctuary trauma, that's what so many of our patients have experienced when they've gone for help, sometimes gone for help to us. And we hadn't understood at all what really had happened to them. And so we started really just asking ourselves and them the question of what does it take to be safe in the world? What does it take to create a safe environment? And we started to see the way violence emerges in any environment, really. We started to think about, well, safety usually to people just means physical safety, but actually we're talking about these 4 dimensions of safety: physical safety, psychological safety, social safety, and moral safety. And that physical violence actually emerges out of these other contexts, not really just spontaneously of and by itself, unless something's really wrong with somebody's brain. And so we started to see the complexity of this whole subject, and it meant that we had to learn to listen to our patients. We had to really listen to their stories and try to clear out the obstacles that unintentionally we had often created for them. So, for example, the diagnoses that we have to give people in order to get service doesn't adequately capture the complexity of the problems that my patients had. They would have 3, 4, 5 different diagnoses, and for any clinician, it's hard to know what in the world do you do with that. What do you respond to when somebody is the only reason they're in the hospital is because their life is in danger in some way. So we had to reckon with the complexity of this subject, and then we had to learn a lot. We had to read everything that there was about these issues, and there wasn't much in 1985, 1986. And then I got a chance to take a workshop with 2 people who have become very prominent in the field, Judy Herman and Bessel van der Kolk. And honestly, it was a workshop in Aruba for a week, so why not? And but actually, I didn't get to see much of the beach because they brought together this research and clinical experience from all different kinds of survivor groups. At the time, in the 1980s, there were different titles given to if you had experienced rape or domestic violence or disaster or the Holocaust. Everybody had a different syndrome. And what I walked away from that experience of learning, was that no, it's all the same. It's very much the same thing, that this is the physiological and psychological reactions to overwhelming stress that are very, very human, and that it could happen to anybody. And there wasn't some special group of trauma survivors that really, in some way or other, we were all likely to experience some really overwhelming event. And that propelled me into action. I started teaching a lot, and I joined the International Society for Traumatic Stress Studies, and that allowed me to get to know people from all over the country and different parts of the world who were real pioneers in doing this work. And then my whole life changed. It became really about what to do about that, and nothing is the same as it was then. When I first started lecturing about trauma and teaching other people about what we were learning, I was in a suburban community, actually an almost rural community, and people were curious, they were interested. Some people would go, it would ring bells immediately. They would understand exactly, and it was for the first time they had the words to describe something they had experienced. That was what we saw in our patients, was that it was incredibly liberating for them to have concepts and words to describe what they had just experienced as something that detracted from their life and made them less valuable as people. And so there was an incredible liberation of the knowledge, and I experienced that whenever I taught. It was really wonderful, and it kept me going, extending myself in ways I was not prepared for as a physician, to really be a teacher. I wasn't. But it was so important, I thought, to get this knowledge out into the world. And as I got more and more activated, I got more and more involved, closer and closer to the city where my roots were, and got more involved in socially activist organizations that would take this knowledge and try to figure out what to do to put it into practice. Resistance, I know there's been resistance. It's been a long time. I've been talking about this for 30 years now. So, but I think it's more about the spread of knowledge and how long knowledge takes, particularly when it's knowledge that challenges the status quo. And I think for people to wake up to the notion of how many children are abused, how much sexual abuse there is, how much rape and domestic violence has been a series of social movements that have enabled that to happen since the 60s and the 70s, beginning with the civil rights movement, and then all the feminist insights about rape and domestic violence and child abuse and child sexual abuse. It's been a long movement, I think, all about articulating human rights and focusing on many different groups of people who have the right to live in peace and live in safety, and don't have that in the present. I think as a result of my efforts, I've seen a lot of change occur, but I haven't done any of it by myself. My colleagues and I created these ideas around the sanctuary model. I started writing about them, and when you write, it's like sending a message in a bottle out into the ocean of information. And so other people pick up the bottle and go, what's inside that? And that's really what writing has been for me. It has been that way of communicating with this whole other world. And it's led to the development of a researchable model of organizational intervention that we call the sanctuary model. And we've been fortunate enough to be able to train a lot of organizations, particularly because here is where we live, in the sanctuary model, so that we could get whole groups of people on the same page at the same time, and decrease the silos. And then also it enables different pieces of our system to communicate across it with a shared language and a shared understanding of this whole issue of trauma. But that really has been the creation of so many people. It never could have happened by myself alone, and that's part of what's, I think, really exciting, is that this really is all about connection. I guess the advice I'd like to give to other communities, other cities, is dig in, start doing something. That one of the things that has been impressive, and one of the reasons why I wanted to really do this project, was to see the difference that individual effort can make. And particularly when individuals are set their minds to connecting with other individuals, to create whole different systems of interaction and meaning. And that's what I'd suggest to other people who want to do this work, is first learn about it. Be prepared to be a teacher, because no matter what level you're at, no matter what you're doing, you're going to have to teach these concepts. Put them into your own language, in your own frames. And then start talking to people. Start bringing people together. You have to do it out of passion and heart. It's spreading knowledge is not currently very fundable activity, so you have to do it because you care and because you want to have the gratification of knowing that these ideas and the knowledge we have is spreading, and that it means that we get better outcomes. Whether it's an individual interaction or a whole community acting together, the outcomes are better. It's kind of practical. A colleague of mine in my department asked if I would be willing to do a webinar And webinars are a good way to, teach people. You can get a lot of people online at the same time. But as I thought about that, I thought, well, why don't what I'd really like to work on is a project that brings together all of, or at least some of, my network of people that I know have been working on trauma-informed issues for now a long time. And I'd like them to talk about what they've done, because they come from so many different pieces of the system. And I thought it would be really a good way, not just for a webinar, but for a website, for other communities to have access to it, build on it, network to it, because I think that's what we need nationally, are these networks of people that connect to each other. The original idea was, I'm involved in ACEs Connection, which is a social media website to really inform everybody about the issue of adverse childhood experiences. And I was to dinner with the person, Jane Stevens, who was a journalist who really started ACEs Connection. And she challenged me. I can't remember exactly what Jane said, but it was something about, well, you have a lot of people involved in Philadelphia, but I don't see a whole lot happening. Something like that. And I went, oh, really? Okay, well then, I want to tell Jane, and I want to tell other people about how many people are, in fact, really involved in this in Philadelphia, because I'm really proud of what's happened and what's happening. But it hasn't been anything that's been centrally controlled. It's really been a kind of emergent, self-organizing network of people who are doing something and taking action in really all of the different systems in Philadelphia, so that something is happening that's really exciting. I hope that anybody that's viewing these videos and listening and watching what we're talking about, I hope that what they get from it is stimulation, that individuals can do things and can join with systems to really create movement. And I hope they get affirmation that of what they're already doing. Oh, somebody else is doing that as well, so they feel less alone. This is hard work, and focusing on trauma and all that people go through is very painful. All of us probably would like to live in a bubble that everything's okay here in the United States of America, in our major cities, and it isn't okay. Things are not okay. Most of our health and mental health problems we know now are preventable if we would just take care of children and take care of families. And we're not doing that. And Philadelphia is a remarkable workplace for trauma-informed care, because we have so much trauma here. We have the city, we are the 5th largest city in the nation. We have the highest rate of deep poverty. We have an extraordinary level of violence in our communities, and similar levels of child abuse and domestic violence that are everywhere else. So it's a really good test ground, and I think we, the big we, have been feeling so helpless for so long as to what to do with these big problems, that changing things really does begin with having a different framework. It begins with changing what you know and how you understand the world around you. And that's what trauma-informed care and trauma-responsive services are really about. They're really about changing the frame. And that then leads to all different kinds of things that we do differently. But it begins with thinking, begins with having a different knowledge base. And we have that now. And that's really exciting, and I want everybody to know about that. A big part of why I wanted to do this project was I wanted to illustrate the difference that individuals could make. So these are, everybody on this website are individual people working in their own way in their own settings. But what they illustrate is the connections that they make with so many other parts of their system. How they are the drivers, they are the leaders of how you drive action to actually occur. And I think that interaction between the individual and the group is really important for people to know, so that nobody's working alone, but alone you can make a difference. And I think everybody on all of these interviews, they are all people who are making a difference in the lives of others. The way I got these people involved, really, I asked them. That's really all it took. I think every single one of these folks has such a passion for what this all means and what this could mean to our culture that I asked them if they would do a video interview, and they said sure. So it was really actually easy, and my university had the resources and said sure when we posed the project. So it wasn't really very difficult at all, and I think that speaks to the heart of the issue, is that this is an issue that means more to people than just a job. None of these people are just doing a job. They are committed to social change. Some people who are watching this may have heard about the stages of change model, it's a useful way to think about behavioral change. It starts with pre-contemplation, which is really, you haven't really given much thought yet to any kind of change you're going to make. And then contemplation is when you're thinking about it, maybe I'll make a change. And then preparation is when you're actually getting ready to make a change. Action is the change. And then there's maintenance, how do you maintain a change? And then the possibility is always there of relapse, that you go back to doing something that you did before. It's a really useful way of thinking about individual behavioral change and how that occurs. But thinking about it, it's interesting to think about it in terms of a larger groups of people, and whether that works for like a whole city like Philadelphia. And I think maybe it does. So I think that we've spent a long time, centuries even, in pre-contemplation, not really knowing anything about this issue, or really, in those days, not really even articulating child abuse as child abuse. And then there was the period of contemplation. So throughout the 50s and the 60s and the 70s and the 80s even, kind of learning about this survivor group and this bad thing that's happened, and child abuse, naming it for the first time, first child physical abuse and then child sexual abuse, and what rape was doing and how common it was, and domestic violence and how common that is, and then all of the other research about disasters and disaster victims and Holocaust survivors and everything post-World War II, really. I mean, what the 20th century has been called the century of megadeath. So I think that was all the contemplation stage, really learning about how many people had been hurt, how many families had been injured, and the first research really about trauma survivors. And then we got to the 80s and the 90s and the 2000s, and that's really been about really preparation, laying the groundwork for the change that need to occur, getting out the knowledge, having the early pioneers in taking action start to try things out and see what might be helpful. And now I think we're at the action stage where a lot of preparation has been gone into this. And that's why, part of why I wanted to do this, I wanted people to understand that this had been going on for a long time, but They wouldn't have seen action necessarily before because we hadn't gotten to that point yet. We are at the point where lots of people are taking action on what trauma-informed care means. A lot of people in Philadelphia, but a lot of people all over the country. And that is tremendously exciting. And then we'll have to figure out how to keep it going. So the maintenance stage is, how do you keep the change going? How do you not slip backwards and go back to old ways of thinking and old ways of acting? And that's the challenges. I'm passing the baton on to that. That'll be for the next generations to figure out. But I think it's really important that we have some kind of historical perspective to know that we have made improvement, we have made change, and we have a lot more change ahead. A number of us from Philadelphia and from other parts of the country have just created a what we hope will be a national policy organization. We've called it the Campaign for Trauma-Informed Policy and Practice. And we hope to be able to inform government, Congress, and the executive branch about the ways in which trauma-informed care and trauma-informed services need to be embedded in every piece of legislation because the problems are so universal. At a local level, I think the policies that I want to see happen are in development, are starting to be rolled out, which is that trauma-informed education is universal. That certainly in all of our medical, healthcare, and graduate programs across the board, that trauma-informed services are implemented at the university level for the students. And then down into high school and into grade school and working with families, that I really see this as the major public health challenge for this century. That we need a tripartite kind of approach, that we need policies that are directed at universal education, and I call those trauma-informed, so that everybody understands these issues, what they do, what stress and overwhelming stress does to the body and the mind, and the way we interact in our relationships and in groups. So everybody should know that, like everybody knows that smoking isn't good for you. People didn't know that in the 1950s. So I call that trauma-informed as primary prevention in public health terms. Secondary prevention is more about people who are already at risk for more bad things happening. So the bad things have already happened, and now they're at risk for further bad things happening. And I call that trauma responsive. So secondary prevention for me is about, or secondary intervention is about having all of our services really not just be informed, but also have policies and practices that respond to their populations. And then we need policies directed at tertiary services, so really trauma-specific treatment, because there are lots of methods out there now, not all of which have an evidence base yet, which are very effective, but non-traditional in helping people to actually heal and recover and get rid of symptoms. Things that often take into account the creative arts and creative expression. So it means that we have to have policies that allow different sectors to interact. We need working artists to be working in mental health settings. You know, we need mental health people to be working in healthcare settings. To truly have integrated services at every level is the policy direction that I think needs to occur. I have a vision for what I'd like to see in, let's say, the next decade, the next 2 decades. If all of our work has been successful, in my imagination, I and every other woman in Philadelphia, we are all able to walk the streets of Philadelphia and be safe, not worry about physical or sexual violence. That we have a city where the shooting has stopped, where young people no longer have to worry about whether they can go out at night and they're going to be shot by accidentally or on purpose. Where we've given up the notion that punishment works very effectively, because it isn't very effective, and that we have a more compassionate attitude towards each other, while at the same time expecting better behavior. Our social norms have changed so that it is no longer acceptable for people to bully each other. It's no longer acceptable to enjoy violence, which is currently what happens. It is no longer acceptable to hurt children. We've just changed as a culture. Nobody made us do it. We just have learned that it is not in our best interest for human survival for us to go on hurting children in any way. And in order to have children be safe, we have to have families be safe. And in order for families to be safe, then we have to change our economics. We can't have people living in poverty. Poverty in and of itself is not traumatic, but it creates circumstances within which trauma is more likely to occur, and it is constantly stressful. So for kids to be safe, families to be safe, we're going to have to make big changes in our social norms. We're going to have to decide that human welfare for everyone is more important than a certain small segment of the population being way better off than everybody else. That's just not going to work over the long haul. So that's my vision, or at least a partial vision of what I'd like to see in the future.